Bismillahirrahmanirrahim. Assalamu alaikum, dear audience. Today my topic of discussion is about a very interesting case which presented to my clinic, that is cornea plana. So today we will discuss about its clinical features, possible complications and their management. When we talk about cornea plana, it is an inherited disease and it has two forms: autosomal dominant type 1, autosomal recessive type 2. Type 2 is a severe form. Basically what happens that the angle between the cornea, eyeball doesn't remain like a sphere. Cornea becomes flatter, and because of the flattening of the cornea, the angle with the sclera is affected. Not only this angle with sclera is affected, because now the cornea is flatter, no more bulging over there. So what happens that the anterior chamber depth is decreased, iris is prone to develop adhesions, iris abnormalities may develop. These patients may develop in severe form slit-like pupil and corneal opacities. So all these things are happening in these highly hypermetrope patients, because refractive error, because of this flattening effect of the cornea has gone now flattened. So their patients may present to up to plus 10 or more hypermetropes. So the most important thing in these patients when we talk about is the earlier diagnosis, because it is genetically inherited. So gene mutations have happened and it persists in specific age area or in population. So what happens that it has to be picked up earlier, and children should be prescribed glasses and compliance should be done over there, because these children are very prone to develop amblyopia. Yes, so basically this is the most important thing when we examine our patients in the children. Usually we do the keratometry in our all patients undergoing cataract surgery, and we know it is around about 43 diopters. But in these patients, because of the flattening effect in type 1, the corneal keratometry may go down up to 38. And in the severe form, it may go down up to 28. So this is the basic thing which is contributing to the hypermetropia. Now I mentioned that one thing is that we have to prevent the amblyopia in these patients. The second most important thing is that because of this small eyeball, now we can say, these people are prone to develop angle closure glaucoma. So very important to regularly monitor these patients for the development of angle closure glaucoma. And later on in the stage, when we have to do cataract surgery, it is quite challenging to do the cataract surgery in these patients because of the small size of the eyeball. Especially calculation and finding a proper intraocular lens. So all these are a few problematic things which may be encountered. Photographs which I have shown, these are of my patient who presented to me. Here you can see that the cornea is flattened, small sized, and there is you can see that there is a haze over there superiorly all around the cornea. So these things happen, and the anterior chamber on the slit lamp, we see that it is the anterior chamber depth is also decreased. Another photograph, here you can see that because of cornea plana, there is we can say that arcus lipidosis is happening over there, that phospholipids are getting deposited, and that opacification superiorly and inferiorly happening over there. So these things happen with the flattening of the cornea is over there. Let's have a look at the corneal topography of this patient. It is showing us 29.4 and 31.4. This is K1, K2. This is a type 2 cornea plana, severe form of the disease. And because of this flattening effect, we have also seen there are changes superiorly and inferiorly in the cornea, and the patient is hypermetrope. Corneal topography of the second eye. This cornea plana is a bilateral disease. Here again you can see that K1 is 33 and K2 is 31, and this patient has got astigmatism of 3 diopters. So bilateral disease basically with very reduced keratometry. So look at the further parameters. Corneal thickness, spatial profile. We can see in both eyes it is outside the reference range. Then we can have a look at the percentage thickness increase. That is also outside the normal range, reference range. And if you look at the reference indexes database, all are affected in both eyes. So all these things are happening because of the flattening of the cornea. And as I mentioned in the corneal topography, it is severely flattened corneas. This is the endothelial cell count. Here you can see that in both eyes it's a bilateral disease, but still cells are maintaining their hexagonal pattern and the cell density is still in the normal healthy range. Showing the axial length of this patient, here we can see that the axial length on the right eye is 23, while on the left side is a little bit decreased up till going up to 22. Otherwise, the other parameters we have already discussed, K1 and K2, both eyes are affected, going up to almost 30s. So these are the things which are very important when we are doing IOL calculation and selecting a proper lens. So these patients, as I mentioned, they need a regular follow-up for the angle closure glaucoma, and especially if we present to us these young age, they need proper glasses use in compliance to prevent the amblyopia. If you talk about the corneal transplants, not that much successful, and these patients do not show the promising results with the corneal transplants. So this was a case which I wanted to discuss, a rare disease which can present to our clinics. And I hope my today's presentation about this disease will be beneficial to my respected audience in their clinical practice. Thank you.